Good evening, everyone, and thank you for joining us for tonight's Woo You special event. We are with Dr. Brandon Ayers, and he's going to be talking on entering the corneal crosslinking revolution, planning and post-op care for crosslinking. So I'll be your host tonight. My name is Dr. Ariel Sorenzi. And a big thank you to Glaukos for supporting this event with a medical education grant. So this will be worth 1 hour of CE credit, so please be sure to attend for a minimum of 50 minutes. For your COPE certificate, please fill out the survey link that will be in the chat shortly, and it'll also be there when the webinar ends. CE certificates will be delivered via email and sent to ARBO with your OE tracker numbers. But we'll also have a QR code at the end of the event if you have an OE tracker app on your phone. Otherwise, those CE certificates will be emailed to you within 4 weeks. We'll save questions towards the end of the presentation, and you can ask those either in the chat section or the Q&A if you're on your desktop. And then if you're on your phone, you can find the Q&A either at the top there, that top arrow, or the chat under the 3 dots under More. So before I get to introduce our speaker, we're going to launch a poll for just a minute or two. So go ahead and fill that out for us. All right, so I will go ahead and introduce our speaker for tonight. So Dr. Brandon Ayers is a board-certified ophthalmologist at Wills Eye Hospital, and he specializes in anterior segment surgery. He has a particular interest in complex anterior segment reconstruction and repair of traumatic eye injuries. His expertise also includes all forms of corneal transplantation, as well as refractive procedures and cataract surgeries. As an attending surgeon at Wills Eye Hospital and co-director of Corneal Fellowship, Dr. Ayers is an active participant in resident and fellow education, as well as clinical research. He is the youngest recipient of the Golden Apple Award at Wills Eye and has been listed in Best Doctors in Philadelphia, New Jersey, and listed as the of the top 50 ophthalmologists in the United States. He continues to lecture nationally and internationally at numerous academic conferences, and we're so lucky to have him tonight at Woo You. So go ahead, and we look forward to having you take it from here. Oh, and then here are his financial disclosures, all of which have been mitigated.
All right, guys, thank you so much. Those introductions always make you feel a little bit self-conscious. Now, I took a public speaking course, and they say when you're talking in front of an audience, if you have your hands in the air, which looks a little funny on a camera, but it's supposed to make you feel more inviting and a little less intimidating. So I don't know if this is working right now, but I'm trying my best to get everybody involved, and I hope everybody enjoys our talk tonight. So we're talking about entering the corneal crosslinking revolution. We'll talk about planning, treatment. We'll go over the actual cross-linking procedure, and then some of the post-operative care, the typical post-operative care, and some of the trouble you can get into in the post-operative care. And if we have time, we'll talk about a couple of future directions and some new things that we're doing with keratoconus that can sort of piggyback on top of collagen cross-linking. So once we're pretty confident that we can get the cornea stable, then what can we do to get patients better beyond, glasses and contact lenses? So let's get started. You've already seen my financial disclosures. They haven't changed in the past couple minutes, and I'll try and make sure that I don't let any of those financial disclosures or financial relationships impact what we're talking about tonight. Now, for a long time, whenever we were discussing keratoconus with our patients, I think what patients would actually hear was a little bit discouraging, and it would sound a little bit something like this.
Well, it's pretty clear on exam that you have a condition called keratoconus. Keratoconus is a situation where the cornea, which is the front of the eye, goes from being very spherical to being cone-shaped, and that leads to reduced vision over time. Now, unfortunately, this is vision that sometimes can't be corrected with glasses or regular contact lenses. You might need to use some kind of specialty contact lens. Over the next several years, you may find that this keratoconus gets worse. Right now, there's really nothing that we can do to help prevent that progression, and about 20% of patients will end up progressing so far that they end up needing a corneal transplant. That means you and I will end up going to the operating room, we will take off the misshapen cornea, and we'll put on a new cornea. It may take a year, sometimes a year and a half to heal, but it should keep you with good vision. All we can do is watch, so I'll bring you back in a month or two and we'll recheck your prescriptions and see if things are changing. If it gets bad enough, we'll talk about doing surgery.
Well, if I was in that chair looking at myself, I wouldn't be too excited about having keratoconus. Nothing I can do. It might get worse. Maybe I'll have surgery. Let's see what happens. Well, the whole goal here is to change that discussion. And that is the welcome to the revolution when it comes to treating our keratoconus patients. Now, it doesn't seem that long ago, but collagen crosslinking was FDA approved back in 2016. Seems like just yesterday that we finally got the okay to move forward in the US with collagen crosslinking for both keratoconus and post-refractive ectasia. We were part of some of the pivotal trials to get collagen crosslinking approved. We've been part of the trials to get epithelium on collagen crosslinking approved. But so far, there is only one protocol that is approved in the US and one company that's approved. So it's very difficult to be biased when you're talking about collagen crosslinking when there's only one company that can provide the riboflavin or the UV light, at least for an FDA approved indication. I am not talking about crosslinking under a research protocol with an appropriate IRB and consent form. Now, the idea for collagen crosslinking is not new. We've known about this since the early 2000s, and we really credit Theo Seiler in Dresden, Germany. In fact, the protocol that we use, or the recipe that we use for collagen crosslinking, we actually call the Dresden protocol because it came out of Dresden, Germany. Theo Seiler actually realized when he was doing collagen crosslinking on bunny corneas that it would actually make the tissue stiffer. It made it less compliant, and he thought, hey, I wonder if this may actually help reduce progression for ectatic disease, because just because you can biomechanically alter the structure of the cornea doesn't mean that it's going to help, but luckily it did. And the way this works is riboflavin drops, or vitamin B2, which is a yellow vitamin, is used to saturate the cornea. And really, to get the riboflavin into the cornea nicely, you have to make the epithelial defect, or at least with the riboflavin that we typically use. So that's why we do epithelium off. The riboflavin is activated by UV light. This activated riboflavin reacts with reactive oxygen species, and it essentially methylates or cross-links the collagen fibers of the cornea to physically, biomechanically stiffen and strengthen the cornea, which can then go on to reduce the progression of keratoconus. So what actually got cross-linking approved by the FDA? Well, the initial studies, the inclusion criteria are listed in front of you right now. We allowed, of course, collagen, not collagen cross-linking, keratoconus really is a dystrophy or a disease, corneal disease of younger patients. So we had to include some youth. So the cutoff was 14 years of age or older. Of course, you had to have a topography that looked like keratoconus, K value of 47 or more, or an IS ratio greater than 1.5. You had to have reduced vision on the eye chart. And of course, in research institutions, we're always going to be using the ETDRS chart, and a corneal thickness of 300 microns or greater. A lot of people get hung up on 400 microns, but in the FDA study, the cornea had to be 300 microns or greater. And as you may know, the indication for collagen crosslinking isn't keratoconus, it's progressive keratoconus. So we had to show that these patients were getting worse, over the past 2 years. And that could be by an increase in 1 diopter in your steepest K value, an increase in a diopter of astigmatism, half a diopter shift of myopia, or steepening of the cornea that requires a change in the base curve of your contact lens. So we had to show one of those things to allow enrollment. And then once enrolled, we would do the Dresden protocol. And lo and behold, it worked. Now, not only did it work, it actually showed some flattening of the cornea. So looking over the course of a year, patients in the study who were given a placebo continued to steepen for about a year, about a diopter over the next year, versus patients who were treated where they ended up having about 1.6 diopters overall of flattening. So not only did they stabilize, they actually had a little bit of regression. Now, what did this look like over time? Well, if you follow these patients at month 3, 6, and 12, of course, patients who did not get treated and were progressing continued to progress to that diopter of steepening. And by about month 3, we saw about half a diopter of flattening. By month 6, a diopter, full diopter. And then by month 12, about 1.6 diopters. So this is really interesting because in a lot of the literature looking at collagen cross-linking, you see a progressive change in the shape of that treated cornea over the course of years, not days, weeks, or months. So we use some of this data to try and figure out, well, when are you stable after cross-linking to recheck your glasses or get refit with your contact lens. And for the most part, we're using somewhere around 3 months as the first time it might make sense to try a repeat in your contact lenses or get refit. And myself, this is the non-scientific part of this. Myself, I just say, hey, look, you can probably try your contact lenses again, but I'd like you to try it in the presence of your contact lens specialist to make sure it's fitting okay and they're happy with the vault and it looks like it's doing a good job. Some patients will shift quite a bit, others very little. So you're never quite sure if that is going to be the right contact lens for you after you're treated. And we've seen some big changes in corneal shape in some patients, almost to a scary level in some cases. But that's the FDA pivotal trial. So now for the first time, in history, right, we have an approved treatment for keratoconus that is preventative instead of reactive, like corneal transplantations. Like, wow, well, you've gotten so bad, I guess now we have to do surgery. But we were just kind of waiting for things to happen. We weren't really doing anything to try and intervene. We were just kind of crossing our fingers and hoping that patients wouldn't get better. Now we can cross-link the cornea instead of crossing our fingers. And this really changes the discussion that we can have with patients and the discussion that we have with patients' parents, which may even be more important, especially in those younger patients. And now it sounds something a little bit more like this.
Well, it's pretty clear from exam and also looking at some of your diagnostics that you've got a condition called keratoconus. Keratoconus is a situation where the cornea, which is the front of the eye, goes from being spherical to being more of a cone shape, and that leads to reduced vision over time. Now, we're really lucky today because your doctor has picked this up very early, and your cornea is still in pretty good shape. A couple years ago, there wasn't much that we could do, but now we have a treatment called collagen crosslinking, which is FDA approved to help stop the progression of your keratoconus. It's going to require a procedure in the office, and it takes about an hour, hour and a half to do, but it's going to take the keratoconus and it's going to stop it from getting worse. This way, over time, the worst you're going to be is the way you are right now. We're not likely to move on and have to do any additional surgery on you, so you're going to be fine for the rest of your life.
So to me, that sounds a lot more encouraging than the old version of this discussion, where it was just basically, hey, you've got keratoconus. Good luck with that. I'll see you in a couple months and we'll see if you're getting worse. But now this also changes what we need to do in the office. Years ago, when patients would come in with keratoconus, we would have our topography, we would talk to the patients, but I didn't really have to document that much, except that the cornea maybe had some apical thinning or maybe some apical scarring, and you could see the irregular astigmatism on topography. Now we really have to show that that patient is progressing, or is that patient stable? Because if we're going to get the patient cross-linked, Again, it is not for keratoconus, it is for progressive keratoconus, and we have to in some way show that the keratoconus is progressing. So this is what we're now looking for in these keratoconus patients. Looking at topographies, we're looking at refractions, we're looking at contact lenses, and of course, we're looking at the eye on slit lamp exam. Now, I showed you the inclusion criteria for the pivotal trials to get collagen cross-linking approved. Now, luckily, the approval process doesn't necessarily have to be the same as inclusion in the FDA study, but it does give us a clue as to what we need to show an insurance company or document in our chart in order to get the approvals to get the procedure done. So we're looking for progression over the course of 2 years. We're looking for that steepening in the K value. I don't know that it necessarily, actually, I do know that it does not have to be a diopter, okay, to get approval, but it would if it was a research study. We need to show or can show a change in astigmatism. We can show that myopic shift, or we can show the change in the contact lenses. All right, so if we show any of these 5 things, that leads to some evidence that this patient is progressing. We can put that in our notes, and that helps us get our patient approved for collagen cross-linking. The easiest way for us is to just show that change on topography, but that means that I have to have more than one exam or a comparative topography to compare against now. So there's got to be a lot more sharing of information with the referral eye care professional and myself, or whoever the eye care professional is who's going to be doing the treatment, so that the more data we have early, the earlier I can show progression, the sooner I can get that patient approved for cross-linking. So here's just one example of a patient of mine where you can see an obvious, tomography really of somebody with keratoconus. We can see the crab claw. You can see the steep K value. The K max here is 49.7. And then a year or so later, everything has gotten worse, and our K max value is now 52. So this is an easy one. You can clearly see this cornea is progressing. This is the right eye. The left eye is also progressing. Now you got to be careful. You can't just look at the color change on the Pentacam, because the color scale can be changed. But the K max value here, 44.7, and now we're at 45.6 a year or two later. Now, if this was going to be a patient who was enrolling in a research study and we were only basing it on the K max value, it wouldn't qualify as an entrant into the study because we didn't hit our diopter. But it definitely is enough to show that this patient is progressing, and it will be enough to allow for an insurance company to approve collagen cross-linking. We've had to fight this battle several times. Now, what I love is the comparison displays, being able to look at exam 1 and exam 2, basically subtract the 2 and see what's going on. And so here, when we compare an exam from 2019 to 2020, we can see in that third, that difference A minus B, that image all the way on the right, that there is clear progression from A to B. This cornea is getting worse. And so there, right there, that is our proof that this patient is progressing. And here on this tomography, the same thing, we're going to do an A minus B, and you can see that plus 1.1, that yellow spot all the way on that image on the right. That means this cornea has steepened in that area by about a diopter. This is proof of progression. And this is just an easy way to look at the data to see if somebody is getting worse over time. Now, it gets a little bit trickier after treatment when you're looking for stabilization. Now, changes in refraction is a great way and an easy way, I think, to look for progression. But it is so hard to do a refraction on somebody who's got moderate to severe keratoconus because they've got so much irregular astigmatism. Most of the time, my technicians just give up. We know they're difficult to refract. The irregular astigmatism is much better handled by contact lenses. But if I don't know the contact lens, I've got to find a way for a patient who I really think is progressing. I've got to find a way to show that they're progressing. And refraction is one of the ways that we can do that. So I mean, who hasn't refracted a keratoconus patient twice in a day and gotten a different number each time, right? I no longer allow or accept this notation where, manifest refraction equals no improvement. I want to know what the vision is, what their glasses are, when it was changed, and what we did today. Because somebody who had a best corrected vision of 20/80 last year with a -5 +4 refraction, today still has a vision of 20/80, but it is, -8 +9, right? That's no improvement with refraction, but a very different refraction. And the difference in number is enough to show that this is a progressive keratoconic and should be cross-linked. So it's a little bit of a lesson in futility sometimes, but I always try and get an accurate or as accurate as possible refraction on these patients. And sometimes that means going back, asking the referring eye care professional for, hey, what was your last refraction? So I love getting a letter from my referring doctors saying, hey, I've been seeing this patient for years. I've been watching the prescription change. This is what it was in 2020. Here it was in 21. Here it is in 22, and it's still getting worse. Now, I don't have to work at all, right, to show this patient is progressing. We know this patient's progressing, and it's based on historical data. Now I don't have to say, hey, you know what? I think you probably are progressing, but let's bring you back in another 4 months, recheck your topography. I don't like doing that, especially in that 17-year-old keratoconic patient who, in my heart of hearts, I know is so likely to progress. And if all we can do is stabilize, the sooner we can get to the cross-linking, the sooner we can get that cornea stable. So actually, I really appreciate sometimes when, I have a referring doctor who's a little bit lazy with the refraction, hasn't really checked it well, but has documented a refraction. And then I check it in the office, and it's very different from what was sent to me. That difference in refraction to me and to the insurance company is proof of progression. So now I've got my proof, and we can get the approval much easier. So this really is now critical information, and that exchange of information is as important as ever, or maybe even more important than ever when it comes to treating these keratoconus patients. So that is another critical part at looking at improving progression. Now, once all this data is collected and you have your evidence, we now need to make sure that we have the right code, and we write a very convincing note in the chart that will likely be seen by the insurance provider to try and show that our patient is progressing. So we always use the diagnosis now of progressive keratoconus. Honestly, even if I don't know, I'd rather have the progressive code in there so that they never see a stable diagnosis and won't go back and say, well, doctor, you said it was stable before and now it's progressing. What have you done? I always use that progressive code. We don't have to show anything. It's amazing. I don't have to show a darn thing in my chart except that a patient has keratoconus and they'll approve a corneal transplant. But to do collagen cross-linking, a much less expensive and a much better procedure, I have to show all this data in order to get the approval status. Drives me crazy, but it's the world that we live in, so we got to do it right. And I write a letter like this. Our patient has progressive keratoconus over the past, fill in the blank, 9 months, the refraction has increased by a diopter, the magnitude of astigmatism is also increased. We're seeing progressive, increase in corneal astigmatism or steepness on our topography. The only recommended treatment is Epithelium-Off. iLink is the name branded. You don't have to say iLink, just Epithelium-Off collagen cross-linking, which is an FDA-approved procedure for progressive keratoconus. Risks and benefits have been discussed, and then we send this off to the insurance company. And even with that, sometimes, less now, but when this was new, we would almost always have to go to a peer-to-peer or call someone to get this approved. This is what has gotten much easier over the past, I would say, 5 years. We get a lot less pushback, but every once in a while, I will still have to have a direct conversation with a, probably not an eye care provider. It's usually a family practice, internal medicine, or even an OBGYN, somebody who's a medical director of an insurance provider, to talk about keratoconus and try and get this approved. And that discussion sounds a little bit like this.
Hello, this is Brandon Ayers.
Hi, this is Dr. Smith.
Oh, hey, thanks for coming to the phone. Yeah, we are scheduled for a peer-to-peer on a common patient with a history of keratoconus. Are you an ophthalmologist yourself?
No, I'm not an ophthalmologist. I'm a internal medicine physician working for the insurance company.
Okay. All right, great. I just wanted to make sure I knew who I was talking to. So this is our young patient with a history of keratoconus, and we've seen him 2 or 3 times, and there's pretty obvious progression in his chart, and his vision's getting worse. We're trying to get him approved for epithelium-off collagen crosslinking, or what's called eye-link. Sure. Yep. I've got his chart right in front of me.
And has he had documented progression over the last few years?
So yes, we've seen progressive changes in his corneal steepness over the past 3 to 4 visits. So we're seeing definite progression there.
Is his corneal thickness at least 400 microns?
Corneal thickness is above 400, even on his most recent check.
Excellent. Has he tried or failed contact lenses in the past?
Yep, he has tried contact lenses, can't wear them. Tried them a couple times, actually.
Appears that our mutual patient meets all the criteria for the procedure to be approved.
All right, let me just write down that approval number. All right, thank you so much. Bye-bye.
So that was life for a while, trying to get our patients approved for collagen crosslinking. And like I said, it's gotten much easier over the past couple of years, but still every once in a while, we'll need to make a phone call and really advocate for our patients. Now, the point of having a doctor, in that video that wasn't an eye care professional wasn't to make fun of the situation or of the approval process. But sometimes just a quick explanation of what keratoconus is, what collagen crosslinking is, and suddenly they go, oh, okay, this makes total sense. We should get this approved. So usually if you have all of your ducks in a row, if you have the data and you're pretty convinced that somebody's progressing, it's rare that we get a denial from the insurance company. So the indications again are so now we'll go from our approval process, what we need to show that someone has progressive keratoconus, the data collection, into the actual procedure. So the actual approval indications are progressive keratoconus and progressive corneal ectasia following refractive surgery. Now this discussion is more on keratoconus, but it is the same exact procedure for somebody who's had laser vision correction and now has ectasia. This is an epithelium-off collagen crosslinking, and I do apologize. Sometimes I'll denote collagen crosslinking as KXL and sometimes CXL. If you see either one of those, I'm talking about the same thing. They're not two different procedures. And this was a unique approval. This was a drug and device approval. So it wasn't that they got the riboflavin approved or the UV light source approved. They are a combo unit. So that's the first time that we've seen that in any kind of FDA approval process. But the device, 3 milliwatts per centimeter for 30 minutes of emission, right? That is the Dresden protocol. There are 2 different types of Photrexa. There is the viscous, which is exactly what it says. It's viscous. It kind of has a syrupy consistency. I call it yellow syrup. And then we have the hypotonic solution, which is more of just a liquid. It's more like water, a typical drop. We cannot change any of the parameters on the light source. The only way that I can change a parameter on the light source is by turning it off or shining it away. I can't change the power. I can't change the fluence. I can't change the timing. The only way that you can change the time of exposure is to just move the light off the eye for a while. But we have only one protocol approved. The way this works is we're going to give some topical anesthetic. And I do this in the office, not in the operating room. So it's an office procedure. Topical anesthetic. We usually give a drop of antibiotic and a drop of betadine. We'll need to use something to make an epithelial defect. I use a little device called the Orca, but there's many different ways to make an epithelial defect. You're trying to get that epithelial defect to about 8 to 9 millimeters to really expose the cornea. And then we're going to, every 2 minutes, put a drop of riboflavin on the eye. In fact, the light will make there's an induction phase. And so every 2 minutes it rings a bell. And every time that bell rings, you're supposed to put a drop of riboflavin on. You kind of have nightmares about these bells ringing and putting a drop on the eye. The eye care professionals get that nightmare. Patients definitely get that nightmare when they go to sleep that first night. And every time they hear a bell, they think they're going to get hit by a drop. Now, you saw in that video, they asked if the cornea was 400 microns or more. This is a pet peeve of mine, but it's something that we have to deal with. In the pivotal trials, the cornea had to be 300 microns or thicker to be enrolled in the trial. Now, when we're doing the actual cross-linking procedure, we have to swell or hydrate the cornea to 400 microns before we turn on the UV light. So after about 20 minutes of putting riboflavin viscous on the eye, we'll check a pachymetry and see what that pachymetry is. It's almost always less than 400 microns. We then need to switch and use the hypotonic riboflavin to hydrate and swell the cornea to 400 microns. You can absolutely take a cornea that's at 300 microns or even 250, hydrate it and swell it to 400 microns to make it safe to treat. So we will often fight the fight for patients with thinner corneas that they can still be safely cross-linked as long as we hydrate the cornea to bring the stromal thickness up to 400 before we actually turn the light on. Now, once we have all that done, we've got riboflavin on the eye, the epithelial defect is made, we've put our drops on, we've made sure that it's 400 microns, then we can basically turn the UV light on, center it over the cornea. We continue to apply riboflavin every 2 minutes, but that light will sit over the eye for 30 minutes. Again, that's our Dresden protocol. After the light is performed, the light gets shut off, we move it away. We'll usually give another topical anesthetic, put a bandaged contact lens on, and then send the patient home with probably some pain medication, as well as topical antibiotics, steroid, and maybe a topical NSAID to help with discomfort. So that's the typical office procedure. I can show that to you in video form here. Now, those two X's, those are the Heaney lasers. And when those two X's cross each other, that's when you're at the proper focal distance for the light. Right, so here we are in the induction period, just every 2 minutes, putting the riboflavin on. We check the corneal thickness, it's 330, too thin to turn the light on. So we'll switch to the hypotonic riboflavin. You can see that yellow fluid. Every 2 minutes, we'll keep going. Now our cornea is at about 400 microns. It's safe to focus that light and turn on the UV. So see, we're gonna center those crosshairs on the cornea. Then we'll hit the go button and you'll see that green light. Patients will see it as blue. We see it as green because of the riboflavin in the cornea. Every 2 minutes, that patient continues to get riboflavin drops and they just stare at the light for 30 minutes. It is not an exciting procedure, but it does work very well. Now, our standard post-procedure protocol, I like to use a bandaged contact lens after the procedure. It helps reduce pain for some. And I do warn patients, it will be uncomfortable for a couple of days. That contact lens also helps reduce mechanical trauma to the epithelium, even by blinking. We place our patients on topical antibiotics and an anti-inflammatory steroid about 4 times a day for 1 week, or until the epithelium heals underneath the bandaged contact lens. I typically taper the steroid over about 4 weeks. There are different protocols. My way is not the way, it is just a way. We would like to see that epithelium healed by 3 to 4 days after the procedure, very similar to somebody who may have had PRK. We do not like delayed healing, as it can induce haze in the cornea. There have been some studies that looked at one type of bandaged contact lens material better than another, and it seems like both of the major formulations work pretty well. Now, here's what things look like kind of in a graph from day 1 to week 1 to month 1, okay? Or month 3 or 4. Day 1, we're going to use typically a fluoroquinolone antibiotic or polymyxin, depending on allergies, plus a steroid, topical NSAID for pain, and some narcotics. I will actually do my 1-day checks. I check on everybody the day after the procedure. I know they're going to be uncomfortable. I tend to do my 1-day checks as a virtual visit. It really works well. Nobody wants to come back to the office with an eye that's painful. Some patients have traveled in quite a ways. I can get a pretty good look at the eye and answer any questions virtually. If there's any question of a problem, they need to return to the office. Now, by week 1, we really do expect the epithelium to be healed. The bandaged contact lens is typically removed. I'll then stop the topical antibiotic as long as there's no epithelial defect, and we begin the steroid taper. Typically, I'm using either loteprednol or prednisolone at 4 drops a day. Every week, we'll decrease it by a drop a day, very similar to the way you would taper steroid if somebody had a cataract surgery. The vision is usually worse on week 1. Okay, the epithelium has just healed, and we have wiped away all of the epithelial remodeling that's happened over the course of years to try and round out that keratoconus cornea. That's going to take a couple of months to rebuild and reshape. So I tell patients that at first, and this has been shown in studies, For a little while, your vision will get worse. Then it should come back to the way it was. It may even get a little bit better. You may already see a little bit of stromal haze, which we'll call a demarcation line in the cornea, which really shows that the patient was treated, and it shows that there was a reaction in the cornea. I'd like to see a little haze. I'd like to see a demarcation line. To me, that means that the treatment took, and we're likely to see stability. If the patient still has an epithelial defect, then I think we have to consider patching or another therapy to get that epithelium to heal. And we'll talk more about delayed healing in just a couple minutes. By 1 month, we are off topical drops. Okay, you'll likely still see a demarcation line or a little haze in the stroma. It may be very difficult to see, but it should be there. Vision still may be reduced, but patients will be feeling much, much better. And this is when I think I bring up, okay, should we treat the second eye? If you talk about treating the second eye the day after surgery, every patient will say no because they're in so much pain. It's amazing how quick memory fades for painful procedures. A couple of months ago, I had to have my collarbone operated on. I was hating it for a couple of days. Now, if I had to do it again, I'd say, okay, let's do it. So, but about a month, I think, is when patients forget, but it is very, very important to make sure that if both eyes are progressing, we get that treatment done on both eyes. So you don't want to forget about eye number 2. And it is really easy to do that. You kind of think, hey, we got away with it. You're done. You're healing well. But then you got to realize, wait, this is our patient. Most patients have 2 eyes. Most keratoconus patients have keratoconus in both eyes. And most of the time, both eyes are progressing. Now, a few months after, this is where I think the patient's vision should be getting back to baseline. Now I think we're talking about, changing refractions, getting glasses changed, trying your old contact lens, trying a new contact lens if necessary, and really getting that patient back to their primary eye care team to try to get the vision seeing again. And I'm very careful when I discuss collagen crosslinking with patients. They don't hear what I say, okay? But I say it to everybody. Collagen crosslinking will help stabilize the cornea. Glasses or contact lenses or specialty lenses are how we're going to keep you seeing. The crosslinking will prevent you from getting worse, but it is not necessarily at this point a therapy for vision. It's just for stabilization. And I'd say half the patients kind of forget about that, but I do document it on every exam because there is a lot of confusion. They think they're being cured of keratoconus and they're not. We're just stopping the progression. Now, what if the epithelium doesn't heal? This is where things get to be really, really challenging. And if you are co-managing a patient who's been cross-linked, knowing how to troubleshoot this, I think, is critical. You can see bacterial infections and bacterial contamination in patients who, when we culture the contact lenses, bacteria are around. Now, luckily, most patients don't get infected. We think that even the UV light itself helps to sterilize the eye, so our rate of infection is very low, but you may see them, and I do have at least 2 patients over the past about 8-9 years who have had a bacterial keratitis after collagen crosslinking. So I do warn them that it can happen, although that it's unlikely. Now, it does seem that mechanical removal of the epithelium heals faster than laser removal, like a PTK type procedure. In keratoconus patients, their corneas are not normal. Not only are they abnormal in shape, there are abnormalities in the nerve plexus, and we see more neurotrophic keratitis in patients with keratoconus than you would in some other conditions. We've picked that up in young patients with keratoconus who had to have a corneal transplant where they would have non-healing epithelial defects in some cases, and you couldn't figure out why. This is a 28 or 38-year-old patient, should be healthy as can be, and they can't heal their cornea. Well, there are some sensory abnormalities in some patients with keratoconus, and that can cause problems when you're doing a procedure that creates an epithelial defect. And honestly, I probably should, but I don't necessarily check corneal sensation in every keratoconus patient who comes in. Maybe we should change our protocol, especially when someone's going to be having, a surface procedure. But right now, that's not part of our standard protocol. So what if you get an epithelial defect that looks like that one? So let me walk you through a clinical case. This was my very first patient that I treated after FDA approval for collagen crosslinking. He's a patient, 35-year-old male with a history of Down syndrome, referred in for keratoconus diagnosis and management. And I thought, man, this is a great case. We really would like to try and stay away from corneal transplantation, due to the difficulties managing these patients and suture removal and the higher risk of trauma and graft dehiscence in patients with keratoconus. So we talked to the patient, we talked to the family, great candidate for the procedure, and he actually tolerated the procedure very, very well, remarkably well. But at week 1, okay, our contact lens was removed, and he still had about a 3 by 4 millimeter central epithelial defect, no infiltrate. This did not look infected, just the cornea didn't heal all the way. We got about halfway to 2/3 there, and then it just quit on us. So very concerned for delayed healing. I don't want that epithelial defect to stay because it can lead to haze, scarring, and it's an open wound. Just because it's not infected now doesn't mean it won't be infected down the road. So the thought was, and I think the right thing to do, is sometimes that bandage contact lens really sits tight and it pushes on the apex of the cornea. You take the contact lens off, maybe put some ointment on the eye, patch it for a day or two, or just use ointment, and usually these will heal up pretty quickly. But not this time. A week later, really very little to no improvement in the epithelial defect, but luckily still no infiltrate. Now, again, this is a big kid, right? 35-year-old with keratoconus. The patients or the parents admit it's really difficult to get ointment in his eyes. He doesn't like it. We can't force it in there. I'm afraid I'm scratching his eye with the drops in the ointment. So we talked about using a self-retaining amniotic membrane. AMT can be very helpful at healing epithelial defects. But they said, before you try this contact lens, you might not like that. Let's just try maybe a patch overnight. Well, he doesn't tolerate the patch. He rips it off when he gets home. And so they come back the next day, still have a scratch. And we say, forget it. We got to put an AMT on the eye and see if he's getting better. Now, this is not this patient, but it is a representative photo of a self-retaining amniotic membrane. So we're trying this, and I'm almost positive this is going to get things better, but it doesn't. He hates the patch. He hates the AMT, still has slow healing. We left the AMT on for about 2 weeks, but it just didn't work for us. So now we're talking more, and I'm starting to think, man, this is not getting better. So our next step is, well, why don't we try some autologous serum? Well, I'm not able to draw this patient's blood, but his mom volunteers and says, you can use my blood. I've not done that before, although we've used it in infants where we use maternal blood for autologous serum. I said, okay, let's give it a try. But my recommendation was tarsorrhaphy. Tarsorrhaphy really works in patients with non-healing epithelial defects. Just a temporary tarsorrhaphy, lateral third of the lid. I hate putting them in myself. Patients don't like them, but a tarsorrhaphy works. If this was today, we probably would use some nerve growth factor as well. When I was treating this patient, we did not have recombinant nerve growth factor, so it wasn't in my protocol, but that certainly would be reasonable to do. Now, what I didn't know is that the parents of this patient was right in the middle of a nasty divorce. And every time we were trying to make a decision, they would go talk about it in the waiting room and get into this massive fight. And everybody would get involved and they'd have to be, escorted out of the office. So, maybe doing collagen cross-linking right in the middle of a nasty divorce isn't the best thing for the patient. And I think in this case, it may have actually impacted some of his care. So now we're on autologous serum. Still not getting that much better, but there's lots of evidence that things like autologous serum and PRP, things of that nature, platelet-rich growth factor, can have some of the secret sauce, if you will, some of the hormones and growth factors and fibroblast factors that help the epithelial defect heal. We use a lot of autologous serum for non-healing defects. Finally, we're getting the epithelial defect a little bit smaller, but not healed. The family says, let's try a standard bandage contact lens one more time before we go back to the OR to do a tarsorrhaphy. Lo and behold, I don't know why a BCL didn't work the first time, but it was enough to get this small epithelial defect healed. So we finally got this patient to healed before he had any infectious keratitis. And he's actually done quite nicely, although he does have a little bit more haze than I would like where we did the collagen cross-linking. But he has never needed a corneal transplant. He is still very functional with his vision. So I guess in the end, it worked out for him. But, getting these patients to heal reduce toxic medications, remove the contact lens, consider ointments and short-term patching, self-retaining AMTs, autologous serum or PRP, sometimes a combination. And I forgot to add it, but I would also strongly encourage topical human recombinant neurogrowth factor if these defects are not showing any improvement and there's a neurotrophic component to it, and there often is. You will see haze. I'm not afraid. I don't mind that deep stromal haze that we see after collagen cross-linking. This fades over time. You can actually see the depth that we got the cross-linking done. It's usually in the deeper stroma, somewhere between 200 and 400 microns. And that will fade over time. And after a year or two from cross-linking, I can't even find it. Okay. The haze you get from PRK or from a slow healing epithelial defect, very reticular, very anterior, and it definitely can impact quality of vision. So we like to get these corneas healed as quickly as we can, because if we don't, we could be dealing with the bacterial keratitis. So I want to get through this pretty quickly, because this isn't really a talk on infectious keratitis, but it does fit into treating patients postoperatively who have a procedure that requires an epithelial defect. These are those patients who are going to call day 2 or 3 going, I was doing okay, and holy cow, now I have this terrible pain, my eyes red, my vision's getting worse. They sometimes can even see a white spot on the eye. Now, at the slit lamp, you're also going to see, dense AC reaction, maybe even a hypopyon. You hope you don't. You hope you don't see something like this. And I guess my real suggestion, if you do, is nobody wants this in their office. Get it to somebody who likes treating it. I don't like treating it, but we do. And it's necessary to know how to treat it. Okay, you definitely don't want to see a keratitis that looks like this. All right, but this is, we have had at least, or I have had one case of a patient who had an infection so bad that he required a corneal transplant. Most common offenders are going to be staph and strep. With the bandage contact lens, you can't rule out gram negatives like Pseudomonas, Serratia, and Moraxella. The patient who I treated, most recently with an infectious keratitis after cross-linking was Moraxella. There are a few cases of fungal infection. Smaller infections, you can continue to treat with a fluoroquinolone maybe every hour or 2. We like to cycloplegic them. And you can add polymyxin. Polytrim does a very nice job against gram-positives and MRSA. So a nice combination is maybe every 2 hours of fluoroquinolone plus polymyxin. If you have access to culture, you can. But I think many of these cases get treated empirically without doing any kind of a culture. If you have a bigger, badder ulcer, you're absolutely going to want a culture or send to somebody who will. You can even hold on treatment if that patient's going to see somebody that day. Probably would use fortified antibiotics in this case, not necessarily fluoroquinolone and polytrim. But if that's all you've got, that's all that you can treat with. Now, future directions. Epithelium on collagen cross-linking is what we all want to do. But most of the literature right now shows that it does stabilize, but not as much, or in some cases, not at all. There have been a couple of FDA studies. We've been involved in at least 2 of them now, where it has shown that it stabilizes the cornea, not as impressively as epithelium off, but it does stabilize and you get much less pain. Now, the advantage here is you can turn collagen cross-linking into almost a coffee break procedure where there's very little pain. Some of these protocols are using higher fluence in the light, so there's more energy, which means shorter treatments. We can also use an increased level of oxygen. The collagen cross-linking procedure requires riboflavin, those reactive species, collagen fibers, and oxygen. Oxygen drives the reaction. When you turn that light on, oxygen levels in the corneal stroma immediately drop. So with some of the epithelium on protocols that are in study, we've actually used hyperbaric or higher oxygen concentrations. We actually have patients wear these goggles that are connected to an oxygen tank, and we make sure that the oxygen level around the eye is above 90%. So adding this oxygen does seem to accelerate and enhance the collagen cross-linking procedure. Now, the first study using oxygen is completed. The data did meet its endpoints, but it hasn't actually been published yet. So we are still finishing up another study looking at epithelium on collagen crosslinking with slightly different versions of riboflavin that have these kind of activators to help get the riboflavin through the epithelium. Higher levels of oxygen. This study is randomized, it is masked, and it is crossed over. So we have about another year to go on that one. But I think that once this study is done, we may finally have FDA approval for epithelium on collagen crosslinking, which all of us are really rooting for, especially our patients, because I think it will reduce some of the complications that we can potentially see with epithelium off. Now, corneal tissue addition keratoplasty is a new procedure, and this will be the last thing that we show. But this is a new version of keratoplasty unique to keratoconic patients that is planned based on pentacam measurements. And what we're doing is using a strip of treated cornea, making a pocket and putting it into the patient's cornea. So this is kind of like a biological intact. Now, another name for this is CARES, which is coined by Dr. Susan Jacobs over in India. CTAC is basically a brand name, and this is the branding isn't in the procedure or what's being done. It's in the technology to design the corneal insert. So here we are, we had to put some marks on the patient's cornea, and we're using a femtosecond laser to create channels in the cornea. This patient has already been cross-linked. So we've stabilized the cornea, but now the patient says, well, what do I do to get a little bit better? I'm not happy with my vision. I'm not doing great with contact lenses. I'm glad that my cornea is stable, but now what? So this is what CTAC is for. It's a step before corneal transplantation. So you can see there that we made channels in the cornea, and now prepared by the eye bank, okay, and this is specific for this patient based on the patient's pentacam measurements. They've created this corneal stromal insert. This is irradiated cornea. So this is biological tissue, but there's no antigenic material in this. So what this means is we don't have to worry about rejection. We don't have to worry about lifelong steroids with these segments. It is like putting a new 2x4 in the wall if it's not holding up very well. That is the little CTAC segment. It's a little ring or rim of cornea. You'll see that better in just a moment. It comes packed in albumin. This can actually sit on the shelf for several months. So this does not have to be fresh tissue. We don't need good endothelium. So we can use donor tissue that might not be adequate for traditional corneal transplantation. We're now going to go to the operating room, and we're going to open up those channels that were created by the laser. We'll use clockwise and counterclockwise dissectors. And in the interest of time, I'm going to fast forward a little bit because we are coming up on our hour. Because this is the really neat section. This is that corneal insert made of biological tissue, so different from intacts that are made of PMMA. We're now going to put this insert into the channel, and right in front of you, you can see the change in the shape of the cornea. You're going to get a lot of flattening. Now, these inserts go at about 200 microns deep, so they are more anterior than where typical intacts would be. So instead of bowing tissue into the anterior chamber, it flattens the cornea front surface. It is a little bit challenging to take this kind of wiggly noodle and put it into that channel. But with a little convincing and some special instruments, this was actually a very early surgery. We've now designed some instrumentation to better perform the procedure. But we're going to get and work that segment all the way into that channel. And you want to get it to match a map that was sent to us by the eye bank. So we're not just putting this in anywhere. We want it to align with it should sit in a predestined location, which looks like this. And so I've overlaid where the programming says that section should sit and where I put it. So that it is now in the right spot. This does not take any sutures. We use a BCL. I don't even know that we need the bandage contact lens, but I put it on just in case the patient felt a little bit from where we were manipulating the cornea. And very quickly, we'll see some flattening of the cornea. So I believe this is the patient's pre-op, and they're the post-op measurements. You can see the difference in keratometry, a much more regular topography. There is data on this. There's some science. This was, I think this is Peter Hirsch's data and Steve Greenstein, who really are piloting these programs and are responsible for the software to design the CTAC segment. So I think this is a really great way to help patients with keratoconus have, lessen the impact of the cone, especially once they've been stabilized. In this case, the patient ended up going on, this was an older patient with keratoconus, went on to have cataract surgery. And this just shows that the CTAC segment does not get in the way of the cataract and significantly change the power of the lens that we implanted. And there, once again, is the topography overlaid on top of the cornea during the surgery. So that is CTAC, or corneal tissue addition keratoplasty. Some people will call it corneal tissue addition for keratoconus. So FDA approval of the Avedro collagen cross-linking system, or iLink, has really changed the landscape for the treatment of keratoconus. But now we really need to look at topography, refraction, contact lens tolerance, and keratometry to follow these patients, because we need to prove progression. And if we get progression, collagen cross-linking is the answer, and we need to get that into our patients' hands, which sometimes means being an advocate for your patients. Post-operative care is a must, and being able to deal with some of the bumps that you may find in that post-operative patient, it's nice to have your hands on, but certainly if things get a little bit bumpy, it needs to get back into the hands of the person who did the procedure in the first place. We now also have some newer technologies for those patients who have been stabilized to try and further treat the keratoconus without being as invasive as a corneal transplant. We have come up just about on our hour. I'd like to thank you guys for spending the past 56 minutes and 20 seconds listening to me ramble on about collagen cross-linking. Hopefully you found it enjoyable and you can apply this to your own patients.